Other people can see it. So everybody needs to push the little button. Hi, I'm Gene Ransom with MedChi, the Maryland State Medical Society, and we're doing a demo from Dr. First today, and we have Aaron Bull with us from Dr. First to give us that demo. So essentially, the EQUIP program has three quality measures: BMI, medication reconciliation, and then end of life. They're all claims-based measures, which means they have to be performed on the patient in question, and they have to be billed as a CPT code. So essentially, medication reconciliation and BMI are pretty straightforward, and most doctors, no matter what their specialty is, are able to do it. But end of life can create complications for certain specialties. So MedChi has been looking for someone to partner with for folks who are in EQUIP that could help them meet the end of life requirement. And that's what we're going to hear about today. Dr. First is a Maryland-based national e-prescribe company that's expanded into other telehealth platforms and has had Backline up and running for what, Aaron, a good 5 or 6 years now?
It's actually close to a decade now.
Oh, is it really? Wow.
Yeah.
So, and Backline really picked up in use during COVID as a telehealth product, and they've now expanded it to a real clinical use tool. So, with regards to end of life, they've actually partnered with another practice that are providing the end of life services, and it does allow you to meet those equipped quality measures. So, without further ado, I'm going to turn it over to Aaron. Are you able to share your screen so you can pull the slides up?
Well, let's hope so. I've got it here. I just didn't want to cut off while you were talking, but I think we should be in good shape. Uh, Bear with me only because oh, here we
No,
go. There
there
we
we
go.
go. All right, Aaron, it is all yours. I will turn it over to you, and you can go ahead and talk about how people can use Backline for advanced care planning.
Well, fantastic. And good morning, everybody. And thank you so much for joining and taking the time. As Gene said, I'm Aaron Bull with Dr. First. We're here to talk about advanced care planning and our secure communication tool and routing platform and how that might be able to help you with end of life planning. So, to that end, before I get into it, just a little bit, Gene mentioned Dr. First, we're a Maryland based company. We've been in business 24 years. We've been doing a lot of what we do for a while. You can see some of the statistics on the screen. We work with over 350,000 healthcare professionals, 220,000 prescribers, over 235 million prescriptions are written across our software annually and dispensed, over 20,000 ambulatory facilities. We work with over 270 EHR partners where we help drive some of the functionality in their EHRs and 71,000 pharmacies. And as our name implies, from the founder on down, the concept of the company is to look at problems that exist in the delivery of care from the doctor's perspective, hence the doctor's first, and how we can align with your workflows, help make your life better, and allow you to achieve what you need to achieve every day. So to get started, I thought it would make sense to take a look at some of the statistics around advanced directives. And ACP and end-of-life care. So as to frame it out. So through going through multiple studies, we can see 79% of adults believe they should have one, but admit they need prompting. 67% believe it would prevent them from receiving unwanted treatment, which is important. 82% believe their family would want one in place. And aligned with that, 74% of them say it would probably prevent familial disagreements on care. And 96% believe it should be created when healthy, so not when in an urgent situation in an acute setting. Yet, despite all of that, only 7% of adults are being engaged by providers, and less than 6.8% of Medicare FFS or original Medicare beneficiaries have any ACP activity, which really leads to the question of if there's such a demand, what's going on? Why isn't more happening? Well, as it turns out, it is and it isn't, but it's complicated. So for patients, when they're polled, it's an emotional conversation that can be difficult for them. They have a fear of impact on their relationship with their provider. They have big concerns about family dynamics, a lack of complete understanding as to why. Believe it or not, the overwhelming majority respond that they believe it's you, the doctor's responsibility. And When we talk to providers, bigger issues are with everything that needs to happen every day, uh, in all the clinical workflows, is there's insufficient time, resources, training, and tools available, which leads to how we decided to look at the problem. And in looking at it, we really broke it down into 4 steps throughout the process. Obviously, at a detailed level, there's a little more back and forth, but to be able to talk about it. And just to orient in this slide, the way we've designed the system to work, and we'll get into some details, is basically these 4 simple steps where if you look at the bottom portion of the screen right here, the provider only really needs to be involved in the first step. The patient, of course, is consistent throughout the journey, software, and then the ACP specialist that will be able to connect them to. So we just need them to be prompted, let them schedule a conversation. They will have one or more conversations as appropriate. All the items will be documented, and we'll also provide back to you KPI reports, which we'll get into and show you to let you see how your patients are moving through the system and if they stalled out anywhere. Now, as I get into this, just a couple things to keep in the back of your mind is while we would provide a platform which allows you to start this conversation from a patient point of view, there is nothing they need to download or install. It is accessible via their laptop, desktop, or cell phone, and that is the same is true for you. And as a referring provider, there's actually no cost on your end to do this. So what we'll do is we're going to take a step through each of these 4 bubbles so you can see exactly what everything looks like and how it progresses. So enrollment, the part that providers involved with, it all starts with a click. So what you see on the screen here is representative of if you were in a chat in our software on a desktop version, that's the monitor. Very simple to use. If you've used your cell phone to chat with anyone, you can absolutely use this. It's just as simple. Difference being, obviously, our application has much more functionality, plus it is HIPAA compliant along the way. So here, if you were in the chat with a patient, all you would need to do is in this bottom bar right here, where you would typically type in your message, there's a little arrow, you click it, and then you would click right here, Start ACP. That will launch the workflow and send a message to the patient, which will allow them to get into step 2 and beyond throughout the process. So if you were to click that Start ACP, we're going to take a look from the patient side, and we're going to look from left to right on the screen. And so the patient would receive a link into their text message. Again, this could be to an email address as well. They need to enter their first name, last name, and date of birth. That is done to confirm that the person receiving the message is the person and their identity. This is done for security compliance. Once they do that, they're going to receive a message, which just lets them know that they're in the workflow and that they're going to be able to schedule an appointment, which also then leads to this screen here, where they're able to get, you can see it says that they've been enrolled in ACP and they want to schedule a virtual visit. It can take 30 minutes. Obviously, it can take longer if the patient would like. It's really as much as works for them and they're comfortable with having a conversation about this. Once they click the schedule appointment button right here, it brings up this calendar widget, which allows them to select the day that works for them and the time that works for them. And then they click submit. Once they click submit, that will be scheduled with an ACP specialist. That is all the patient has to do up until the time that they meet with the ACP specialist to move it forward. So if we look forward, as we get to the day where their ACP session is scheduled, they will receive another message reminding them that's here and another one when it's time. for demonstration purposes. We just didn't need to show all of those bubbles. Once again, they click the link that's provided. They confirm their identity with first, last, date of birth. They're going to get a message letting them know that it's time for their visit. Are they ready to join the call? Now, the reality is the provider can see, or the specialist can see that they're there. They don't need to respond. So for purposes of illustration, we can see Jody Smith did respond and said she's ready. Uh, then similar to if you've used FaceTime, Zoom, or WebEx or another functionality, you'll get a joint video chat window. All the patient has to do is click the video button. And again, we are showing just the mobile version, but this works on desktop as well. And then they will be in the session with the provider. Now, throughout this session, they'll be able to have their conversations. We also realize that there may be times where a patient, if they're formulating an advanced directive, wants to go and review the content or review it with their family members, or they may need to get some questions answered for their own sake. So while they're there with that specialist, if needed, they can also schedule an additional time right then and there, and it'll work similar to what we just saw, so that they can meet again and get it completed. And one important thing to note is, as this is done and done with the ACP specialists, the claims that are needed for the quality measurement will be submitted, and that includes even those that did not meet the CMS billing requirement, but the $0 claim requirement with the appropriate modifier so that that quality measure can be captured. So for documentation outside of any EHR that the specialist has, we provide, as you can see on your screen, My Directives, which is the product of AD Vault, which is the premier AD tool out there. So this will allow for documentation of what is discussed. A account will be created for the patient and provided to them there in the session. They will have access to it. Either at that session or a subsequent session, if they want to make this fully executable or executed legal document, they can actually invite the appropriate witnesses in, as you can see on the right side of the screen here, to be able to witness and get that signature put in place. Once it's in there and in AD Vault, that patient has continued access to it. They can share it with caregivers, family members, or anyone they deem appropriate in their continuum of care. For throughout time as they move forward with their life through the process. So I did mention that we would give you some navigations and insights. And so just for sake of discussion, we can see the graph here. Those numbers are not actual numbers based on experience. They are just there as an illustrative set of numbers to show what the reporting looks like. But in essence, it will show as a patient is invited into the system, as they schedule an appointment, as they conduct the appointment, and or if they complete any ACP paperwork, what that trail off may look like. You could have a set of vertical bars and everyone could make it through. Like I said, this was just for an illustration, but you will have insight into that information as we move, as patients move through the ACP process. So what do you get with Backline other than helping to connect the patient with the ACP specialist? Is we're able to minimize the time required to obtain an ACP. Again, no download for the patients are required. This is a HIPAA compliant secure platform. We have a robust network of ACP specialists available to be able to handle the patients. There's no cost to you, the ACP referring provider. It's designed to be an easy to use workflow that aligns with what your clinical workflow is on the day to day. You'll have increased patient satisfaction. As we saw, there is a desire to have this done, just a gap right now in the real world environment getting it done. And we'll be able to, through putting people in this process, increase the capture of the quality measure. With that, I just wanted to thank everybody for taking their time today and meeting here and see if there are any questions that I can answer for you.
So the first thing is, Aaron, so the practitioners, and I know you've got a couple different practitioners, but in Maryland particularly, the practitioners that you're using, they're going to be billing the codes, and that would meet the equip measure. Are they going to bill the modifier if they don't complete a, because it takes 20 minutes under a billing guideline to bill the full thing that they charge for. But the practice is if they bill the modifier saying, yeah, we did a partial, even though the practice doesn't get paid, that helps the referring practice meet the quality measure. Will they be doing that as well?
It's a wonderful question. And the answer is yes. If it does not result in a billable and a money changing hand claim, yes, they will submit the $0 claim with the appropriate modifier, which, if I remember correctly, is the 8P modifier, showing that it occurred, which results in no financial benefit for the ACP specialist, but it will provide you what is needed claim space for the quality measure.
Right. And I know you guys did a lot of work to make sure there were no self-referral issues, and that's why there's no cost or payment or anything, any money flowing to the referring practitioner. So the referring practitioner, which would be the equipped practitioner, simply refers the patient, and your financial relationship is with the specialist who's providing the advanced care planning, correct?
That is absolutely correct.
So that's that. Any other questions from anybody else on the call?
So I have a question. So I think it's just to clarify that last statement there. So again, as a specialist, is there a way for us to um, not do this on everybody, but only know once we know who qualifies that then we can refer?
Uh, Wonderful question. And absolutely. Actually, we would prefer you only refer the patients you want in. So when we go, I'm just going to hop back a couple slides here. So, okay. So when we start here, where it starts with a click, so actually, what I would envision is whether it be in the exam room or whether you use front office staff, but this, what you can't see on this screen, and just because we can only show so much in the PowerPoint, is you will have more or less like your patient roster, who you want, off to the left. So when they're in, if they qualify, those are the only ones you have to go in and click Start ACP and put them into this workflow. So the
Right.
answer
So,
is
so, so,
yes.
and then, the other thing, Dr. Hidalgo, is we could also run your list of Medicare patients, and then have we could just pick who we want to send over and just pick them, frankly. So you don't have to send everybody over. We can use CRISP to do that. And your Quip entity can help you with that. And I know you happen to be in one of the MedChi entities, so we could certainly do that. And Colleen at MedChi, or some of the other, actually really it's Sean and Raquel and some others who actually staff the CRISP unit, can help run a profile, and then we could send it out. You could even do something like just take all your Medicare patients and then maybe send them a note saying, hey, we're just trying to increase end of life education. I'm going to refer you and reach out, and then you can let them know it's coming, and then you could put them in the system. And that's one way you could do it. But you can certainly pick who it has to go to, and you can decide.
Okay, great. No, that's very helpful. Because as you know, right, based on my specialty, these are discussions we don't typically have, but I definitely see the importance of it. And now knowing how it affects the EQUIP program, that how can we incorporate it so it makes sense for the patients who we will eventually be for the Medicare patients. So that's great. Thank you for answering.
Yeah, in fact,
Thank
well, I
you.
think the way to do it is to really have a strategy around it where you just pull your whole Medicare, we pull your Medicare panel, and then you reach out to them and say, "Hey, we're doing this as a public health service. We want to make sure that you have access to it. It's no obligation. You don't have to do it if you don't want to, but we thought it made sense, and refer it out, and hopefully you'll get enough who are interested, that they will go ahead and do it. That probably is the best way to do it.
Okay, what if the people who are that qualify for the program that we're looking at do not reply?
Well, if they don't, or they don't do it, then we just have to have a certain percentage, and it's not a crazy high percentage. So that's going to happen. I think you're going to have a large number who don't respond or partially respond. And that's why I asked the question about billing the non-paid modifier, because I think it's important that we, get credit for the work we do. And that way we get credit for the quality measure, even if the advanced care planning specialist doesn't get paid.
Okay. But we as specialists can do that non-paid modifier
If you do the work, yes.
if we do the work. Okay.
Yeah. You
Okay.
can also do the paid modifier. The issue is that frankly, for your practice, the paid modifier is 20 minutes, right, Aaron? I'm pretty sure it's 20
Hmm.
minutes,
It's
right? So,
yeah, the paid the billing is it's a minimum of over 15 minutes and up to 45 minutes gets you the initial 30 time-based code, and then you have to cross 46 minutes to get the second 30-minute time-based code.
right. So,
Yes, and when you look at an hourly receipt rate, it's not very generous.
or so like for your practice with your specialty, it doesn't make a lot of sense. Or I see we have a rheumatology practice on the call as well. Doesn't make a lot of sense. Not a good use of the practitioner's time. It really should be somebody else probably doing that work logically and economically.
Well,
Okay.
who qualifies as a specialist? Is that nurses?
There's a by CMS, it can be nurses, it can be some other staff, and they all have to be under a QHP as
Yeah, yeah,
well.
yeah. Okay.
Yeah. So typically, I think, and look, I know Dr. First is working with multiple practitioners, but the practitioners they tend to work with tend to be folks who have background in maybe hospice or maybe their primary care. It's that type of specialist typically, and they're usually working with mid-levels as well. And they're kind of set up specifically to do this. And look, we would strongly encourage in fact, I think for the primary care docs who are in equip, it might make sense for them to do it. That might be logical. It's a more logical conversation there. The complication is if you're an ophthalmologist or an allergist or a dermatologist or a rheumatologist, why are you having a discussion about end of life that can, that may I think it's very important how you communicate it to the patient. All right. Any other questions from anybody else? Thank you, Doctor. Doggo, anything else for anyone else? All right. Well, thanks, Aaron, very much. Really appreciate you being with us this morning. And do not worry, we will send out the recording to the other folks who couldn't make it because they had patients this morning.
You bet. Thank you, everyone, for your time and for having me this morning. I appreciate it.